Hi, my name is Connie Koklanis and you're watching the video on measurement of torsion. In this video, we'll be discussing the various investigations you can utilise to measure torsion. So there are a number of tests that you can use to measure torsion, and we divide them into two types, subjective and objective. The subjective tests rely on the patient to give you information about the torsion, and obviously the objective does not rely on patient reporting, and you will objectively identify the amount of torsion present. Now, here on the left-hand side, we can see a list of tests that you can utilise to measure torsion that are subjective. And the first three, the Synoptophore, the double Maddox Rod and the Torsionometer, are what this video will focus on. Now, that's not to say that these are the only tests. You can also measure torsion with the Maddox wing, Bagel-Illustrator glasses, double Maddox prisms, a Weyer cyclotest and the Hess screen. However, these are less utilised in Australia to measure torsion, and the most commonly utilised test to measure torsion is actually the double Maddox Rod. So in your reading, you'll have a variety of tests to read about, including those that are not included in this video. However, I will focus on the most commonly utilised test. Now, over to the right, we have the objective measurement, and this is usually done by assessing the fundus and either assessing it using indirect ophthalmoscopy or imaging. You can also use direct ophthalmoscopy, but clinically the most utilised technique is either indirect ophthalmoscopy or taking a photograph of the fundus. Now let's commence with the Synoptophore. We have looked at the Synoptophore last semester, and we've also looked at the Synoptophore in terms of measuring in 9 positions of gaze. We've also discussed measuring torsion in 9 positions of gaze with the Synoptophore. What I want to bring your attention to in this video is that there are specific slides utilised when torsion is present. And these are the Maddox slides, and you can see these to the right here, where you have a cross for one slide, and the other slide is a circle that can incorporate that cross. And just a reminder that these here are the dials or the knobs that you will rotate so that you can tilt the slides to correct for the torsion that the patient may be experiencing. So what the patient will have is, in one slide they will have the circle, and in the other they will have the cross. And their task will be to move that cross into the centre of the circle and ensure that it sits perfectly within that circle. So as an example, we can have here a patient who might have horizontal, vertical and torsional displacement of the cross. In other words, using the Maddox slides, you can actually correct all 3 components. And it's somewhat easier to do this using these slides, given that you're not asking a complex question around whether the line is parallel to the cage, for instance, or is the line tilted and then the patient needs to straighten the line up. The issue with this test is that sometimes when the cross starts to move out of the centre, and you will have experienced being on the Synoptophore and the line, for instance, sometimes being in the cage and then slowly moving out of the cage and then coming back into the cage, that dissociative nature of the Synoptophore can make it difficult for patients to continually try to ensure that the cross is in the centre and orientated in such a way that it sits perfectly within that circle. Okay, so coming back to our example, this is a cross that's displaced vertically, horizontally and torsionally, and the patient will give you instructions as to how to move that vertically and torsionally so that it sits perfectly, and again you can ask the patient to move it horizontally. So in the end, what will happen is that that cross should be perfectly in the centre of the circle. Okay, the alternative which we talked about in the last video is that you can use your simultaneous perception slides and ask questions around whether one of the images is tilted and ensure that they orientate the image so that it is straight, so to speak. You can also, in the example of the line in the cage, draw a horizontal line and ask the patient to ensure that this line is parallel to the cage's line. Again, this can be difficult with children, but if you have an adult, this can be relatively easy to explain. And once again, as noted in the previous video, if you do choose to utilise simultaneous perception slides for the purposes of measuring torsion, you must ensure that if you draw that line, it needs to be straight. Do not utilise these slides if the line is not straight. And be aware that once you start manipulating these slides, you are adding a level of risk to your assessment. Okay, moving on to the double Maddox Rod. As I said earlier, this is one of the most commonly utilised tests to assess torsion. And you can do this by either inserting 2 red Maddox rods, and in the prac rooms we will be utilising 2 red Maddox rods. But you can also do it if you have 1 white and 1 red, and you can just see in the photograph below that this child has a white one in front of their right eye and a red one in front of their left eye. Now I should just point out that conventionally you should put the red in front of the right. Just in terms of orthoptically, we often do this to remain consistent with our clinical investigations. Okay, so what are we doing with a double Maddox rod? Well, you will recall that when you give the patient a Maddox rod, or you place the Maddox rod in front of one of the eyes, it will produce a line perpendicular to the orientation of the rods. So if you give the patient a Maddox rod in front of each eye and you shine a light in front of the patient will see 2 lines, one from the right eye and one from the left eye. Now what we want to do is orientate the rods in the same direction in front of each eye. So what we have in this patient here that we can see, you can just see that the rods are vertically aligned, and here as well. And so what the patient will see is a horizontal line from each eye. Now where there is a deviation, there will be a displacement of these horizontal lines. One will be above, perhaps horizontally displaced, and also one may be tilted. So what we're specifically interested in when we're measuring torsion using the double Maddox rod is the tilt of the image. And what we're going to ask the patient is to move that tilted image so that it is parallel to the second image. So essentially we're using one line as the reference, and the other will be tilted in such a way that it will become parallel to the other. And to do this, what the patient will do, or you can do this for them, is rotate this particular dial here so that the lens, or in this case the Maddox rod, can be rotated either anti-clockwise or clockwise to bring that line in alignment or parallel to the other line. Now you would do this assessment in primary position, but you can do it in 9 positions of gaze. But you can imagine that given that your patient is in trial frames, so you have these frames that are fairly obstructive, it can be difficult to get the patient in tertiary positions to measure the torsion. Let's go through an example where a patient is noticing an intorted image. So in this instance, as you can see here, we would give the Maddox rod, or put the Maddox rod such that they are sitting at 90 degrees, both for the right eye and the left eye. And what the patient will see is 2 images. From the left eye, they will see a horizontal image, and the right eye will produce the tilted image. In this instance, it's an intorted image. Now what we see here is that there is a vertical misalignment in addition to the torsion, but there's no horizontal misalignment in addition to the torsion. So just remember that when we're measuring torsion, we're actually not that interested in the horizontal or the vertical. All we want to know is when the lines are parallel to each other. Okay, so that's the question we'll ask the patient. So they will rotate the knob here to the extent that the red line becomes parallel to the white line. Okay, in this instance, the patient is rotating it outwards towards their ear, and they've rotated it 10 degrees. They've gone from 90 degrees to 100 degrees, which indicates 10 degrees of torsion. This is actually 10 degrees of excyclo-torsion. Now, the thing to remember here is that when you record in the history 10 degrees excyclo, what you're indicating is that the eye is excyclo-rotated. The image is intorted, but the eye is extorted. or the patient has an excyclotropia. In all tests that measure torsion, we are reporting the position of the eye, not the image. So even with the Synoptophore that we just discussed a moment ago, when you record the degrees to which the eye is excyclo or encyclo-rotated, you're indicating the position of the eye, not of the image. And this is really important because it can become very confusing if you are not aware that what you've recorded is the position of the eye and not the image. Okay, so in terms of recording, here we have a recording of a double Maddox rod. Often it'll be denoted as DMR, and you'll indicate the degrees. Torsion is always in degrees, either with the Synoptophore, the double Maddox rod, or what we'll see in a moment, the Torsionometer. We always record in degrees. And you need to indicate, is the eye excyclo-rotated or encyclo-rotated? And remember, all you're interested in is the difference between the first position, in this instance the first position was 90 degrees, and where the patient places the Maddox rod, in this instance at 100 degrees, and this will be the indicator of the amount of torsion, the difference between those two positions. One more thing to note about the Maddox rod or the double Maddox rod. If the images are not significantly vertically displaced, it can be difficult for your patient to try and make those two lines parallel as they'll overlap. So you are able to put prisms behind the Maddox rod to create a greater distinction or a greater space between those two vertical lines. The other thing to note is if the patient has a large horizontal deviation, the lines will be horizontally displaced in such a way that they're not above and below each other, but they're horizontally apart. In this instance, you may want to bring them closer with a prism so that the patient can have them above one another, so that they can compare the position of each, so that they can make the line parallel for you. So just the take-home message from here is that you can place a prism behind the Maddox rod to make it easier for your patient to make those two lines parallel to one another. Now the last test we're going to talk about is the Torsionometer. This was actually designed by Zoran Georgievsky at La Trobe University and is utilised by a number of clinics across Australia and overseas. So the Torsionometer consists of a plate where there is a red line, and this is a non-movable line, and we have a green line that can be moved, and you can just see this knob here. You can move it in this way or out this way. This is the front of the Torsionometer, and this is the back of the Torsionometer. And as you move this green line here, this line here will move accordingly across this scale, and it will tell you when the patient actually comes to the conclusion of the test whether you have an excyclo-rotated or an encyclo-rotated eye. So the question to the patient will be to make this line parallel, or the green line I should say, parallel to the red line. It is recommended that you do this test or perform this test at 40 centimetres, and that to make it easier for your patient to make those lines parallel, you should actually move that green line maximally off zero. So as an example, you would move this all the way to the edge and then ask the patient to move it so that it is parallel to the red line. Now you can perform the Torsionometer in 9 positions of gaze, but just a note that if you do this, it must be held perpendicularly to the patient's visual axis. That's the plate. So the plate of the Torsionometer must be held perpendicularly to the visual axis so that you can get the most accurate response from the patient. Finally, let's take a look at objectively measuring torsion. And as I mentioned earlier, usually this will be done with a fundus assessment. This is particularly useful when your patient is not reporting subjective torsion and you want to have a look to see whether objectively you do actually have fundus torsion. And again, patients who might do this to you are patients who have adapted to torsion, such as your congenital fourth nerve palsies. In these instances, you may find fundus torsion, but the patient will not be reporting tilt or torsion being experienced. Now, before we can determine how or what a fundus looks like that is extorted or intorted, we first need to go over what is normal. Now, in order to be able to detect fundus torsion, what you need to know first is what is normal. So the way in which we work out the normal position of the eye is by looking at the relationship between the fovea and the optic disc. So here, if we have a look at the left eye, this is the optic disc here, and this is the fovea depicted as the cross. If you take a line from the centre of the disc and a line from the bottom of the disc, the fovea should sit in between these two positions. And so it should be within the lower 1/3 of the optic disc, or 0.3 disc diameters under the centre of the optic disc. It's worth noting that it is actually normal if the fovea sits anywhere between these two lines, so the centre of the disc and the bottom of the disc. The centre of the disc, this line here, is considered trace torsion. It means you're at the border of normal and torsion. The bottom line also has the same meaning. It is trace torsion. You're at the border of normal and torsion. Let's have a look over to the right. Here I'm giving you an image of a real fundus, and a line has been drawn at the centre of the optic disc here and the bottom of the optic disc. And we can see that here we have the fovea, and it sits within the lower 1/3 of the optic disc, and here we have a normal fundus with no torsion. Okay, so if an eye is excycloadducted or encycloadducted, what we expect is that the fovea will be located above or below this position. So in general, if the fovea is located above the normal position, the eye is encycloadducted or there's an encyclotropia. If, however, it is below the normal position, so here, as an example, the patient has excycloadduction or excyclotropia. This will also apply to the right fundus. Again, if the fovea is above the normal position, we will have encyclotropia. If it's below, excyclotropia. Using the fundus photograph, you can also record the amount of torsion by calculating the angle between the fovea and the optic disc. So what you can see here, you take the centre of the optic disc and look at where the fovea is in relation to this, and using a protractor, for instance, you can indicate the amount of torsion or fundus torsion that exists. There are some issues with this in relation to refractive error and magnification that we won't be discussing in the video, but if you're interested, the paper is available on LMS for you to read. Looking at an example, here we have a fovea that is below the normal position, and what you would do in this instance is draw a line from the middle of the optic disc to where the fovea is and measure the degrees between those two relative positions. And here we have 16 degrees of excycloadduction or of an excyclotropia, which is defined by the fact that that fovea is lower than the optic disc. There is one other way to record the amount of torsion, and this is using the +1 to +4 grading system. This is particularly useful where you haven't taken a photograph and you're assessing the patient in the clinic using ophthalmoscopy, and you don't have the opportunity to measure the degrees, the degree of difference between the optic disc and the fovea. Using this grading system, what it indicates is that each additional 1/8 of a disc diameter is graded as +1 from the normal position. So if we have a look at the patient here to the right, so the fovea is located here. These are the lines here that indicate trace torsion. So here we have the beginning or the border of normal and intorsion, and here we have the border of extorsion and normal. So this line here indicates +1, and anything beneath here is indicating +1. And each line actually here indicates 1 degree. So this is 1 degree from trace, 2 degrees, 3 degrees, 4 degrees, and then we have our +1. So anything within here is +1. Then the next is +2, +3 and +4. And for +4 and above, generally you have the fovea displaced half a disc diameter or more from normal. So in this example, the fovea sits right on the border of the +2. So in the history, it would be indicated that the patient's left eye shows +2 excycloduction. Now what I'm showing you here is a fundus photograph. But this grading system is also utilised when performing ophthalmoscopy in clinic. And when you perform indirect ophthalmoscopy, we have to remember that what we see is not exactly the same as what we see on the fundus photograph. Indirect ophthalmoscopy will mean that the view is reversed. So here to the left, we have the right eye. So we'll be inverted vertically and inverted horizontally. So what does this mean for the torsion? It means that if the fovea is above the optic disc, we have extorsion or an extorted eye, versus if it is below, we have an intorted eye. So you must remember that if you're doing indirect ophthalmoscopy or you're looking for fundus torsion using indirect ophthalmoscopy, you must consider that the image is inverted, and therefore what we've previously talked about so far is actually the opposite. To the right here, I've given you a magnified view, this time of the left eye. And what we can see now is that we're considering the fovea's normal position to be in the top third of the optic disc. And again, if the fovea is higher than this, we're looking at an extorted eye versus if it's lower than this, an intorted eye. Okay, finally, let's come to our case, Miss Jones. She actually had torsion measured. And this is the recording we see on her notes. Torsionometer, 4 degrees excyclo. So, the patient has obviously had their torsion measured with the torsionometer. And what this is saying is that in primary position, she has an eye that's excycloducted by 4 degrees. So for her, what she should be seeing is an intorted image, whilst the torsionometer is indicating that the eye is excycloducted. Okay, so in summary, a couple of things or a couple of take-home messages. If a patient is communicating to you that they see torsion or they have a tilted diplopic image, you should always go to the task of measuring the degree of torsion. And you have a number of investigations that can do that for you subjectively, and if required, you can also have a look objectively as to how much torsion is present. And always remember that when you record the torsion from whatever test we've discussed in this video, you are recording the position of the eye, not the diplopic image. Okay, that brings us to the conclusion of this video. Thank you for watching.